Okay, let's dive into visual disturbance. You've shared your revision notes, and wow, it's a huge topic. Covers everything from, a slight blurriness to really significant changes in vision.
It really does.
So, our mission here is to sort of cut through all the complex jargon
Mm,
and just give you the core stuff you need for your revision, the absolute essentials.
exactly. Think of visual disturbance simply as any abnormal or altered visual perception. It's broader than just needing glasses.
Right, so not just needing a new prescription.
Precisely.
Okay, let's tackle the causes then, the etiology. You mentioned it's broad.
Incredibly broad. So you've got your common refractive errors needing glasses, basically.
Yeah, myopia, hyperopia.
Exactly. But then there are specific ocular conditions, things like cataracts, glaucoma,
Affecting the eye itself.
right, plus retinal disorders, damage to the optic nerve, and, importantly, neurological issues. Think migraines, strokes.
Wow.
And we can't forget medications. Some can cause visual side effects. And systemic conditions, too, like diabetes or hypertension. They often impact the eyes.
That's a lot to remember. Is there an easy way to group these for revision?
Well, a useful mnemonic I sometimes suggest is RUNMS.
RUNMS.
Yeah, so R for refractive, O for ocular conditions, O for optic nerve issues, N for neuro, M for meds, and S for systemic. Helps cover the main bases.
RONMSS. Okay, that's
Yeah.
helpful. RUNMS. Got it. So who's typically more at risk here? What are the risk factors?
It really varies quite a bit depending on the underlying cause, naturally. But age is a big one for many conditions, like cataracts or macular degeneration.
Makes sense.
Family history is often relevant too, both for eye conditions specifically and systemic diseases like diabetes.
Right.
Then there's exposure to certain drugs or toxins, any previous eye problems or neurological conditions you might have had.
Okay.
And lifestyle factors definitely play a role for some things, smoking, for example, or poor nutrition.
Okay, quite a mix. So moving on to how it actually happens, the pathophysiology. What's going wrong?
Again, it depends on the cause from that RUNMS list.
Mhm.
It could be a simple mechanical issue, like the eye not focusing light correctly on the retina. That's your refractive error.
Deal.
Exactly.
Uh-huh.
Or you could have actual damage to the structures within the eye, say the lens in cataracts or the retina in diabetic retinopathy.
Uh-huh.
Then there might be problems along the visual pathway, the nerves carrying signals from the eye to the brain, like in optic neuritis.
Okay.
Or, as we mentioned, systemic diseases like diabetes affecting the tiny blood vessels in the eye. It's diverse.
So when a patient comes in describing visual changes, what else should be on our minds? The differential diagnosis.
Ah, yes. Super important. Need to think broadly. Could it be something acute, like a retinal detachment? That's an emergency.
Right.
Or other optic nerve issues, maybe different neurological events presenting visually, like that migraine with aura, or even a TIA or stroke.
Yeah.
Don't forget medication side effects. Always review the drug history. And again, those systemic diseases, especially diabetes, are key differentials.
Got it. Thinking widely is crucial. Now, how common is all this? What's the epidemiology like in the UK? Your notes mentioned patchy data.
Yeah, that's the tricky part. Because visual disturbance is just a symptom, covering so many different conditions. Getting precise UK-wide prevalence figures is hard.
Right, it's not one single thing.
Exactly. The numbers really depend on which specific underlying cause you're looking at. The prevalence of simple short-sightedness is obviously vastly different from, say, optic neuritis.
Understood. So what might the patient actually report? The clinical features.
Highly variable. Blurred vision is probably the most common complaint you'll hear.
Okay.
But also things like decreased sharpness or noticing parts of their vision are missing, what we call visual field defects.
Like tunnel vision or patches missing.
Precisely. Also double vision diplopia, sensitivity to light, or photophobia, seeing flashing lights or floaters. Lots of possibilities.
So a really careful history is needed.
Absolutely key.
And how do we investigate these symptoms? What tests get ordered?
It always starts with a good, thorough eye examination. That's fundamental.
Right.
Then, depending on what you suspect, you might do visual field testing to map out peripheral vision. OCP optical coherence tomography gives amazing detailed scans of the retina. Fundus photography takes pictures of the back of the eye. Sometimes blood tests are needed if you suspect a systemic cause, like diabetes or inflammation.
And maybe brain scans?
Yes, neuroimaging like an MRI might be necessary if a neurological cause is suspected, and other specialized tests depending on the clinical picture.
Okay. So once we have a likely cause, how is it managed?
Well, the management hinges entirely on that underlying diagnosis. It could be as straightforward as prescribing new glasses for refractive error
Simple enough.
or adjusting medications if they're the culprit.
Mm-hmm.
Surgery might be needed for things like cataracts. Treating the underlying systemic disease is vital if it's diabetes or hypertension, for instance.
Right.
Sometimes vision therapy is useful, or it might require referral to a specialist ophthalmologist or neurologist.
Very cause-dependent. What about the outlook, the prognosis?
Hugely variable, again tied to the cause. Some issues, like refractive errors, are easily corrected with excellent prognosis. Others, like glaucoma or macular degeneration, might be chronic conditions that need ongoing management to slow progression.
So early detection sounds critical.
Absolutely crucial. Early diagnosis and starting the right treatment promptly generally lead to the best possible visual outcomes.
And if things aren't managed well, what are the potential complications?
While the impact can be significant, functional limitations in daily life, difficulty reading, driving, recognizing faces, a reduced quality of life is common.
Yeah, I can imagine.
In serious cases, it can lead to significant visual impairment or even blindness. Plus, you have potential complications from whatever the underlying disease is.
So catching it early and sticking to treatment is key.
Definitely. Early intervention and good adherence to the management plan are vital to minimize risks and preserve vision as much as possible.
Okay, so pulling this all together for revision, the main takeaway is that visual disturbance is a symptom, not a diagnosis in itself.
Exactly.
And understanding those broad categories of causes that RUNMS Mnemonic helps and the sheer variety of ways it can present, that's really crucial.
And that really raises a key question for you as you study. When you encounter a patient reporting some kind of visual change, what's your systematic way of thinking? How do you mentally work through those differentials?
A good question to ponder. For more resources, practice questions, and to really solidify this topic and others for the MSRA, definitely head over to passthemsra.com.
And don't forget there are great free materials too at freemsra.com.
Perfect. Well, best of luck with the revision.